Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Amber Williams. Today's episode features Dr. Kathleen Moore from the Stephenson Cancer Center at the University of Oklahoma and Dr. Isabelle Ray-Coquard from the Claude Bérard Lyon 1 University in France. They will discuss the emerging role of CDH6 as a target for antibody drug conjugates in ovarian cancer, the results and implications of the phase 1 and 2 trials for raludotatug deruxtecan, and the ongoing study of this agent and others. This episode is part of a larger educational program titled Next Generation CDH6-Targeting Antibody Drug Conjugates in Ovarian Cancer, the Science, Strategy, and Signals to Inform Clinical Readiness. For more information on Dr. Moore and Dr. Ray-Coquard, along with the link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi, everyone. I'm Dr. Kathleen Moore. I'm a gynecologic oncologist, professor at the Stephenson Cancer Center in Oklahoma City, where I serve as deputy director. I'm excited to be here.
Hello, my name is Isabelle Ray-Coquard. I'm medical oncologist working in the Centre Lyon Bérard Comprehensive Cancer Center. I'm also professor of the cancerology at the Université Claude Bérard Lyon 1. Happy to be there with you and with Kathy to discuss about this exciting topic of CDH6 and treatment targeting this membrane receptor.
CDH6 or cadherin 6 is this transmembrane protein that is overexpressed in a lot of cancers. And I think we'll talk at the end of this podcast around other solid tumor opportunities, but it's very overexpressed in high-grade serous ovarian cancer without a clear prognostic sort of role.
It will be important to remember that CDH6 seems to be particular of interest in ovarian cancer, but also in renal cancer, where we have seen an overexpression of CDH6 in this tumor. Also, we don't see overexpression in the normal tissue, which is finally something quite good if we want to anticipate the toxicity of treatment moving in targeting this kind of receptor. Beyond that, we also don't know exactly what is the role of CDH6 compared to HER2. For example, it's not an oncogenic receptor, and this is something that will be in the future very interesting to continue to explore with the new treatment we have.
This target isn't new, although R-DXd or raludotatug is the kind of first drug, and I'll talk about it in a moment, to show really promising efficacy. We've been here before. There was a medication called, it didn't really have a name, it was just HKT288 that had a maytansine payload targeting CDH6 in the past. We're very excited about this medication, but had early and unexplained neurologic events. And so the development of that drug was discontinued, and cadherin 6 kind of fell into the parking lot for a bit of time until raludotatug. Raludotatug deruxtecan, or R-DXd, as we'll say from now on, is a very differentiated molecule, though, from HKT288. And I think that's just important to say. I think we all understand this now, that these antibody drug conjugates are basically, there's 3 components, and they really do create very different molecules based on the antibody, the payload, and probably most importantly and least discussed, the linker. Technology really does differentiate these agents from one another. So just because this is another cadherin 6 ADC, it's a very distinct molecule. It has a very different payload, a deruxtecan payload. I think that many listening to this will, of course, recognize that and be familiar from T-DXd. It has a drug-antibody ratio of 8. Payload, as we all know with deruxtecan, has a pretty short half-life. The very stable linker payload. It has bystander anti-tumor effect preclinically and clinically. So that's a molecule. It was brought into phase 1 in a very typical kind of fashion with a dose escalation that identified initially 3 doses of interest spanning 4.8 to 8 mg per kg. The phase 1 was done in a select group. There were a number of tumors that express cadherin 6, but high-grade serous ovarian and renal cells are really the 2 most common. And so the phase 1 was limited right out of the gates to patients that we hope would benefit from this medication. And then moved into dose expansion with an additional intermediate dose of 5.6. So 4.8, 5.6, 6.4, and 8 mg per kg went to expansion. And so we expanded at those doses, discontinued the 8 mg per kg because of a high rate of pneumonitis, which again shouldn't be surprising based on TDXD experience where we saw pneumonitis at the higher dose levels. So the 8 mg per kg was discontinued and dose expansion continued in the other 3 doses. And we presented this, it's actually been 2 years ago now, in just the ovarian population, platinum resistant for the most part. There are a few patients that were inappropriate for platinum. Many had received prior bevacizumab and prior PARP inhibitors. So this was an appropriately treated sort of expansion cohort representing platinum-resistant ovarian cancer. And the response rate was 46%, which if you think about the traditional benchmarks in this space with monotherapy chemo, you're talking about 15-ish%. There were complete responses, but there were only 4 patients whose tumors grew, during the phase 1 participation. 98% of patients who participate saw some reduction in their tumor volume. And again, 46% making that 30% partial response or greater cut point. So it was very exciting. CA125, 55% had what we call the GCIG response. So clear evidence of benefit here with a toxicity profile that really reflects the deruxtecan class of medication. So common but low-grade GI toxicities that were high because cycle 1 in the phase 1, we didn't pre-medicate, couldn't pre-medicate. Once you brought pre-medication in, that came way down. Some hematologic toxicities, most common being anemia, and of course, the rate of ILD in the highest dose range was unacceptable, and that was discontinued. And we can talk a little bit more once we get into the phase 2, Isabelle, about what the final kind of sense of ILD is with this medication. But that was the phase 1 experience. Thus far, there'll be some more data coming out on that as we've just finished that up. That won't look too much different. But that really led to the excitement that led to your trial, REJOICE-01. So I'll flip it back over to you maybe to continue the story of REJOICE-01 perhaps.
Thank you, Kathy. Effectively, at ESMO, we have the great opportunity to present for the first time the phase 2 analysis part of the REJOICE-Ovarian01 study, which is finally phase 2/3 trial. We explore the R-DXd, the patient with platinum-resistant high-grade serous or endometrioid carcinoma. And in the first part, we would like to explore the dose optimization of R-DXd in this population of patients who receive between 1 to 3 prior lines of treatment, including bevacizumab. They were platinum resistant, not refractory. Mirvetuximab before can be allowed, and the patients were not selected on the tumor CDH6 expression. In the phase 2, we have included 107 patients, and exactly as Katie mentioned before, more than 90% received BEV before. 51% of the patients received 3 lines of prior systemic therapy, a little bit less than in the phase 1. 70% of the patients have already received PARP before, and the last primary free interval is between 3 to 6 months for close to 60% of the patients. Interestingly, the tumor CDH6 membrane expression were available for 101 patients, and 94%, much more than we anticipate, were positive for CDH6. And in this group of patients, close to 60% were considered to be highly positive, more than 75%. As said before by Katie, we also see a huge activity with R-DXd in this phase 2, where across all the doses, we have a confirmed response rate of more than 50%, a disease control rate of 77%, and a median time to response very short, about 7 weeks. What is interesting is that in the forest plot, we see a tumor shrinkage for the vast majority of the patients. And when we look at the response rate between the different cohorts, we see that the response rate for 4.8 milligram per kg is 44%, 50% for 5.6 milligram per kg, and 57% for 6.4 milligram per kg. The disease control rate is between 75% for the 4.8 to 77% for 6.4 milligram, and for 5.6 is more than 80%. Interestingly, we also see an activity tumor response across a range of CDH6 expression level, which was determined by a central test where the tumor CDH6 positivity is defined by the percentage of tumor cell positive for CDH6 membrane staining and any intensity. And we really see an activity in all the different membrane positivity, which is really interesting for the future. What we also see in terms of safety profile is that we have more treatment-related adverse event and more treatment-related serious adverse event in the 6.4 milligram per kg cohort compared to the two other. And considering dose discontinuation, reduction, and delay, it was very few dose discontinuation, less than 6%. The dose reduction is below 20%, and the dose delay in 23%. And again, more dose modification in the 6.4 milligram per kg. There is also ILD in this phase 2, phase 3, 3.7%, only 4 patients, only 1 grade 3 at the time of the analysis in the 4.8 milligram per kg, but more frequently in the 6.4 milligram cohort. And so altogether, looking to the activity, but also the safety profile, it was considered that 5.6 milligram per kg as the optimal dose, and this is the dose who will be explored in the next phase 3 step. We will start soon at the US and worldwide level. So we really confirm what Cathy revealed for the first time in the phase 1, and also the population is less selected compared to a population included in the phase 1. The results in terms of activity and safety were exactly the same. This is really encourageous and also gives us the opportunity to think for the drug in earlier line.
I do feel compelled to say I've been very involved in this medication from the beginning, so I am really proud of this particular phase 2 that was led by Isabelle and my partner, Debbie Richardson, because it really did take dose optimization very seriously. 3 doses, randomized, with stratification factors, looking at pharmacokinetics, safety, and efficacy, really trying to identify the most effective and safest dose to move into a phase 3 in a manner that took maybe longer than we normally like. So I'm really just proud of that because I think it's a really patient-centered program. I want to talk about the biomarker a little bit, Isabelle, because, you know, with this panoply of antibody-drug conjugates coming at us in ovary cancer, many of which, at least the topoisomerase 1 inhibitors, most of which do not have a biomarker. They're all coming in all-comer situations with these response rates of 50%, which is great. I do wonder, though, whether or not the benefit of the biomarker is not so much in the initial response rate, which you showed didn't really seem to vary, but whether we will see duration of response or PFS being tied to the level of the biomarker. And I'm just wondering, what do you think future seeing with R-DXd? Do you think that it's going to matter, the biomarker, or do you think it's just really biomarker agnostic with this medication?
This is a big question, and I agree with you today. It's not clear how we will see the results. Why? Because on the response rate, as I mentioned and you say, we don't see a difference, whatever is the expression. But considering the duration of response, the PFS and perhaps the OS, we will see a gradient of activity. And in this case, perhaps we will be in a situation where the level of expression could impact not on the response, but on other outcome, which is at the end something important, and perhaps will be impact on the design of the future clinical trial. For example, if we want to explore this drug in the early setting, but also as a treatment versus as a maintenance therapy, which can be both a situation where the drug could be interesting, but the activity and the range of activity can impact also on this decision. And I agree with you, the biomarker is not finalized. Also, we report the response rates, whatever is the level of expression. We need to have more data to clearly conclude on this topic.
Yeah, and I think we'll get that, we'll get that with continued follow-up of the phase 2, and certainly with the phase 3, we'll certainly have more data, which I think we can anticipate having multiple of these topoisomerase 1 ADCs make it across the finish line. I mean, just statistically, there's so many, there's going to be a few that make it across the finish line, and understanding the relevance of the biomarker beyond response rate may really be helpful in picking the right medication for each patient or each patient's tumor in the future beyond response rate. And I think the other thing to anticipate from your study that I'm excited about is the fact, and really grateful to the patients who participated, because they all agreed to a biopsy coming on the clinical trial to be compared to the archival tissue to really sort out temporal and potentially spatial, but mostly temporal heterogeneity of the biomarkers. So we still have a lot to learn from this ongoing program, and the patients who participated have been just, you can't say enough about the generosity of participating and providing a biopsy so that we can really understand how to better take care of patients in the future. So it's going to continue, I think, to provide a lot of data to us moving forward.
Cathy, what is the activity of R-DXd in the platinum-sensitive population? I know that there is very few patients in the phase 1, but it will be interesting to see what you report at ESMO Gynae for this population with platinum-sensitive relapse.
We did study, and many of the programs have pulled out these patients who participated in phase 1 trials with tumors that were technically platinum sensitive by virtue of a platinum-free interval greater than 6 months, but platinum ineligible for a number of reasons. Maybe because of a platinum allergy, more commonly because of really not having a sense that the tumor was really platinum sensitive, like maybe the prior platinum, there wasn't a response, but they just didn't progress for 8 months. There's this group of tumors that we recognize are not likely to benefit from platinum, but yet they have this platinum-free interval that kind of pigeonholes them in these platinum-sensitive populations. So fortunately, we've been allowed to put them on more effective therapies with phase 1. So 18 patients who participated in the phase 1 had disease recurrences that we would consider platinum sensitive by virtue of a PFI greater than 6. About 80% of them had received prior bevacizumab, 80% of them had received prior PARP. So this was a real pretreated group of tumors. 80% of those that had received prior PARP progressed on the PARP. So a high-risk group of tumors. I think we're starting to recognize this group of tumors as perhaps different than those we would truly consider sensitive to platinum. And when we looked at response rates in this group of tumors, it was 72% with a confidence interval that went from 47% to 90%. So the confidence interval was wide, but still the lower limit of that confidence interval was still a really pretty good response rate. We did look at CDH6 expression, just high versus low, just to get a sense, and it really didn't matter. 18 patients, though, so take that with a grain of salt. But we saw deep responses in both those with high and low CDH6 expression. Interestingly, the group of tumors that had progressed on a prior PARP, which was 12 of the 18, so now we're getting into very small numbers, but the response rate there was 58%. Again, just giving us this sense that tumors that have progressed on a prior PARP may be different, and we may need to think about them a little bit differently. The median duration of response was overall about 5.7 months, although we're still following them. Median PFS was 8 months in this group of tumors who were not first platinum-sensitive recurrence, by the way. These were heavily pretreated. So it's a signal that something we want to follow up on. It's very consistent with other small case series of tumors that were technically platinum-sensitive but have received an antibody-drug conjugate, and I think points us to some opportunities for the future to use this and or other medications, maybe instead of platinum in those tumors that are really definitely high risk for an attenuated response to platinum. Maybe we could use this instead of. Perhaps this is a maintenance, although I think we need to talk about that. but it does open the door for maybe moving this antibody drug conjugate up in lines of therapy into more biologically selected group of tumors. I think that just needs to be studied a little further. What are your thoughts on ADCs in the platinum sensitive setting, Isabelle? Like, are you ready for that, or?
Honestly, after what you report at the ESMO Gynae for the platinum sensitive and what we see particularly for the patient who progress during PARP, also it is retrospective data coming from large phase 3 as PAOLA-1. I think we have a great opportunity to consider this drug alone or in combination with BEV, for example, in this group of patients. And I hope that we will see clinical trial to make the demonstration. Now, I agree with you, the maintenance could be something relevant for population where we know that at the end of the chemotherapy, the patient will relapse shortly. And we know that there is poor prognostic population in ovarian cancer. Also, we have PARP inhibitor in the first line. It's not enough. So trying to use this drug for a large population in the high-grade serous ovarian cancer is something important. I would like also, mention that the rare tumor, if we see some activity, will be something relevant. This population did not bring the same opportunity than high-grade serous ovarian cancer or breast cancer. So exploring this drug largely in gynae, I will be very happy to have this kind of treatment and other. And definitively with the piece of data we have built together, we can say today that CDH6 is an important topic in ovarian cancer, and working on this target and exploring new treatments, including raludotatug deruxtecan, is something that we definitively have to provide for our patients with an ovarian cancer in the near future.
Yeah, I agree. To your point, there is a study, it's not resulted yet, but called REJOICE Pan-Tumor, which enrolled a whole cohort of non-serous epithelial ovarian cancer, clear cell, mucinous, low-grade endometrioid, etc. So that cohort is enrolled. We're just waiting for it to mature, along with endometrial and cervical cancer. So there's maybe a couple other examples of that out there, but that will be our first peak specifically at the activity of these topoisomerase 1 ADCs in a non-serous, like, designated cohort. I think that is the first study to look at that. So that's going to be an important readout that hopefully we'll see maybe in 26. And then the other thing I would just mention is that just with everything, once you have a successful drug, there's more development. So there are other cadherin-6 antibody drug conjugates in development that are worth noting. They are distinct molecules. There's CUSPO-6, which has, of course, a different linker and an exatecan payload. It's presented very early phase 1 data in high-grade serous ovarian cancer with a response rate that was 36%, but in the dose escalation. So I think we need to see what they look like in the expansion cohorts once they get to their recommended phase 2 dose. The efficacy and the side effect profile here may be quite different than R-DXd, and I think we can anticipate that with an exatecan versus deruxtecan payload, which is better efficacy-wise and safety-wise. So it's important that we have another molecule in development. And then there's another one, SIM0505, that has not reported out yet, but is in phase 1 dose escalation. So there are others coming that we're going to need to weigh the risks and benefits of to optimize which one we select for our patients. So it's exciting. I mean, I think you want to have kind of the best drug coming forward. So I think we'll kind of wait and see, but it's good to have options. But I think with that, other things you wanted to mention about the space, Isabelle?
We can perhaps mention that today there is a lot of clinical trial available for patients with ovarian cancer. We speak about REJOICE-Ovarian01. The phase 3 will be open soon for all these patients, and I think that it is important that our colleagues were aware about that and can also participate or addressing the patients. This is something that patients will appreciate, I think.
Agree. Yeah. It's kind of overwhelming right now, the number of antibody drug conjugates in the space. So it's a little it's kind of a tension of really great opportunities for patients, but also making sure that we're designing the studies that are very patient-centered and are trying to optimize the right drug for the right patient at the right time for the right duration. And we're learning as we go and trying to pivot as we learn. So it's a fun time, but also there's a little bit of tension to get it right. And I think really congratulations to you, Isabelle. I think this is just an exemplary study. It's already taught us a lot. It's going to teach us even more. And hopefully we'll get the phase 3 up and running soon.
Thank you, Dr. Moore and Dr. Ray-Coquard. And many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Next Generation CDH6-Targeting Antibody Drug Conjugates in Ovarian Cancer, the Science, Strategy, and Signals to Inform Clinical Readiness, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.